Welcome to our 9th ASCP Annual Town Hall event. I'm Dr. Blair Holliday, the CEO of the ASCP. 6 months ago, when SARS-CoV-2 and COVID-19 were just beginning to be household terms, we knew we'd be facing an unprecedented challenge. We had no idea just how disruptive this virus actually was going to be, and ensuing pandemic that we would have within our nation. But we did know that it was our duty to bring timely information to pathologists and medical laboratory scientists who are at the heart of healthcare during these challenges of times, and of course, the ones doing that and participating in our town hall events. So thank you for joining. Now, over the past 2.5 months, we've talked with experts on topics from pathology and laboratory medicine, included transfusion medicine, the risk of comorbidities around COVID-19, challenges around serology testing, and ASCP's call for a national testing strategy. And it's through these events, we've been able to provide you with information that you need to inform your work and ultimately provide better patient care. So today, we're going to take a look back over the past 6 months in the United States, where we've been, what we've learned, and more importantly, where we have to go. To date, more than 120,000 people have died from complications related to COVID-19. We've seen most of the states in our country implement measures to protect their citizens, from stay-at-home orders to mandating wearing face masks in public. But on the laboratory front, more patients are getting tested of the virus and of its antibodies. And we've seen organizations running multiple testing platforms with providing differing results at times. We've called for U.S. presidential administration to implement a national testing strategy to separate and to provide standards nationwide and to conduct work towards that goal. Now, part of that is an increase in contact tracing, as well as keeping laboratories up to date with the latest research and knowledge that will help them test and treat patients with COVID-19. But every day we're learning something new about this virus. And every day, and the more we learn, the better we're able to help our country be a healthier place. So we can use what we've learned in the past 6 months to inform the next 6. And beyond, we need to talk about how we're going to move forward. We have 3 nationally renowned experts to join us tonight, and I'm very excited to introduce you to the groups and the individuals who will help us navigate the future of this pandemic. And we're going to start with Scott Becker. Scott Becker is the CEO of the Association for Public Health Laboratories in Silver Spring, Maryland. And Scott, before we get started, please introduce yourself, but I want to thank you and APHL for your incredible collaborative work, both in the PEPFAR area with ASCP and your support with the Partners Initiative in the White House under the Obama administration. Scott, please say hello.
Hi, everybody. I'm Scott Becker. I'm APHL's CEO, and Blair, you took the words away. I was going to say we are stronger together. So thank you very much for this invitation. It's terrific to be here with this panel, and I'm excited to be here. Thank you.
Thank you, Scott. Next joining our team is Dr. Michael Mina. Dr. Mina is an assistant professor of epidemiology at Harvard T.H. Chang School of Public Health, the Center for Communicable Disease Dynamics. And again, Michael, thank you for being a leader in this, supporting a data-driven science to guide policy in our nation as we migrate through this epidemic.
Absolutely. Thanks so much for having me here. It's a pleasure.
And last but certainly not least, we have Dr. Joya Mukherjee, and she is the Chief Medical Officer for Partners in Health. And she's also an Associate Professor of Medicine at the Brigham and Williams Hospital and Harvard Medical School. And Joya, again, thank you for your collaboration with the Partners Initiative that Partners in Health has sponsored along with our colleague, Paul Farmer, to support outreach to patients in sub-Saharan Africa for cancer diagnosis. Joya, please say hello.
Hi, everyone. Thanks for being here. It's a pleasure to work with the ASCP again.
Thank you again. Okay, so now before we get to the dynamic Q&A we're going to have tonight with our panelists, I want to remind the attendees and the viewers that you can submit your questions through the Q&A function at the bottom of the screen. And now we're going to move into the compliance language for ASCP or ACCME. Okay. Joya, you might be on twice, so you might want to mute.
I am. I'm trying. My internet is not very good, so I'm trying to hang up.
Okay, let's get started. And in the meantime, you can mute yourself and we can right into the heart of the
I
matter.
am. I'm trying. My internet is not very good, so.
Okay. Let's start straight up with Dr. Well, let's start with Dr. Mina. Dr. Mina, I read a great article in the New York Times today where you were featured, and I want to get straight to the heart of the matter. As you know, it's been predicted that potentially within the next 3 weeks, 150,000 people might die of this disease in the United States alone. Even as alone today, Texas is showing 5,000, Florida another 5,000, Arizona, California 7,000. There's concerns about letting these hot states actually travel in the part of the Northeast where they're trying to do their best to prevent this disease from occurring and maybe even curtailing any U.S. travel to the European Union at all. So let me just ask you, did we jump the gun?
I mean, frankly, yes, I think so. And in particular, the states, unfortunately, that opened up the quickest were also the states that, the cases were not down to where we really want them to be actually be able to put things like contact tracing in place to actually control and contain outbreaks when they're happening. If you open up too early and you have tens of thousands of people getting infected, it becomes exceedingly difficult to try to keep those flames under control. And so I think in many ways we did jump the gun. I have to also say that it's a very real concern. We jumped the gun from a public health infectious disease perspective. But I think a lot of the decision making has to also account for public health economics, and the economy is also public health, and it will also, if we throw the nation into wide-scale depression, then that can have much more lasting and devastating consequences. So I do think that there is a lot of room to try to balance these, but certainly the increases in cases that we're seeing in many states is heart-wrenching, to say the least, because those come with unnecessary deaths.
Well, let me ask you, what do you think the appetite is for the American public to go back to where we were in terms of sheltering in place and in essence, creating more social distancing and creating an environment where we're trying to curtail and flatten this curve? What's the appetite?
Well, I think that was a quote in the Times today. I think it's very. I can't imagine that the country is going to be willing and eager to get back into social distancing. And in my opinion, we kind of had one shot at goal for true social distancing, the type of closure we have just undergone. I think anything we do from here on out is going to be more moderate in its effect and its efficacy. Hopefully economically it will be less consequential, but I think from an infectious disease perspective, we're seeing just how hard this virus is to contain. And I don't think that people are going to be ready to dive into sort of severe social distancing again. I think that it's going to be very difficult.
I'd like to switch over to Scott for a minute. And Scott, as you know, the Association for Public Health Laboratories, which you are the shepherd for the organization, has a crucial partnership with the Centers for Disease Control in both domestic and international laboratory preparedness. In your opinion, what has been the most valuable aspect of that relationship during this COVID-19 pandemic? And I guess, what has it meant for non-public health laboratories as well?
Great, thanks, Blair. So yeah, we have a long-standing and very strong relationship with CDC from the public health lab community and the association, both domestically and globally. I think that what it's done, our sort of historic relationship has set us up well to have the ongoing dialogue that we've had. Knowing all the players, knowing where they're coming from, getting good information on a routine basis, and I really do mean that. There is an ongoing dialogue between the state public health labs and the public health lab community and CDC. I think in this response, because it is so large and it's truly unprecedented, there are so many more players that are involved in the response. So there's players at HHS, there's players at FEMA, of course there's players across HHS, and of course the White House and others. So it is a extraordinarily politicized response, but from the perspective of science, policy, and practice, or maybe I should say science and practice, we work very, very well with CDC. I think one of the things that I think about it from a non-public health lab perspective, the states have been engaged since really day zero. We really learned about the experiences on what was going on in China back at the end of 2019 and certainly the beginning of 2020, and began communicating that with the community. Now, a lot of state public health labs also collaborate with their clinical laboratory community in their state, some better than others. But there is coordination, there is communication. Can always be better, absolutely. But I think just that ability to know who's doing what is important. I will say at the outset, there were definitely the challenges that we encountered with the CDC test failure. That set the entire community back. No doubt about that. There's no way to gloss over that. It was a problem. It did put us behind, but I think having the ability to communicate frequently is really helpful, and I believe that's going to only continue as we are expanding testing across the country.
Let's talk a little bit more about that, Scott. As you know, we talked about this earlier, but we called for a national testing strategy. There was a blueprint that came out of the White House that endorsed that. That's a good move in the right direction. There was not a task force that was ever developed to coordinate the logistical supply chain and for that matter, coordinating at a federal level around testing. So Congress has appropriated, funding for testing, of course. But what does that mean for the states, in your opinion?
So a few things. So I do think it means for a period of time, I think we felt like we're on our own a little bit. The federal government absolutely has coordinated to an extent. And I think that's where we now have to think forward. We know that the Assistant Secretary for Health has moved back to his day job. So I think collectively, our organizations, other organizations, we really need to continue to press and to push for that national strategy moving forward. I think from a state perspective, it means that things are still very challenging. We can certainly, assuming we're going to get to talk about supplies at some point, because that's been an issue. But the funding has been allocated, and that's something that we're very grateful to Congress for. There may need to be additional funding. We don't know. So the very first testing plans went to CDC, and it was really only for a 2-month period. Those were received at CDC just 2 weeks ago. The next phase of the testing plan, which is from July for December, those testing plans are actually, it's been extended. It's now due on July 10th. So we're going to have a lot more to dig into in the coming months regarding what the states are going to go through. But I do think that we're in an okay place. I'm not going to say that things are rosy. They're not. You saw today likely that the states are going to take over the community-based testing sites. They did know about that. There are some places where there are hotspots, and I know those states are very concerned about that, and that rightly so. This is going to be with us for a while.
Okay, let's see if Dr. Mukherjee is able to join us there. Yeah, it sounds like she is. It looks like she's moved from Boston to San Francisco. So
yeah.
You must have a teleporter in your office as well. So let's go ahead and get started. Joya, thank you again. Partners in Health, as you are aware, is leading the contact tracing efforts in Massachusetts. And could you please describe or briefly describe for us what it takes to perform contact tracing? Give me some ideas and share with us the challenges to do this in sparse versus densely populated states. You know, give us the overall view of how contact tracing works and the testing strategy associated with that.
Yeah, thanks. First of all, I want to thank the ASCP for always standing beside Partners in Health. We believe that any disease, any epidemic is always going to be worse among the poor, and ASCP has been an instrumental partner in our global work to provide diagnostic services around the world, particularly for cancer in Rwanda, Haiti, and elsewhere. So I want to highlight that because I think for this pandemic, we see that we are only as strong as the weakest link of the chain. And we understand at Partners in Health that epidemics are very, very local. At the end of the day, an epidemic is in a nursing home. It's block by block. It may be an outbreak related to a conference. And so what is important about contact case investigation and contact tracing is to understand the locality, right? So for every case, a new case that's identified, someone contacts them. And if it's in Sierra Leone, that contact is on foot. If it's here in Boston, many of the contacts, most of them are by phone. And then walks through their day. How long have you been sick? And a couple days before you became symptomatic. And then enumerates those contacts and calls them and instructs them, first of all, if you're sick, and even as we've changed guidelines in Massachusetts, every contact can get a test and is recommended to get a test, and then how they will safely quarantine if they're negative or isolate if they're positive from the people they live with, because most of the spread is within households and among close contacts. And then third is this idea that at Partners in Health we feel is critical, which is giving people the option to say, I can't do that, because we know that social distancing, quarantine, isolation, these are all very economically regressive things that if you don't have money, if you don't have transport, if you don't have safe housing, it's very hard to do that. So if we really want to stop the epidemic, we have to resource the communities, the people, the individuals who are least able to quarantine and isolate to stop the spread. And so contact tracing helps us map where the epidemic is, and it also helps us to resource the places that it is spreading the quickest. And so what that looks like in Massachusetts, Partners in Health is helping the local boards of health in the state. There are 351 of them. And between Partners in Health and the local boards of health in Massachusetts, we've contacted 126,000 cases and contacts. 90% of them we've been able to get through there to and give them this information. And fully about 15% of them need the additional support. And then based on this work, we have been now asked by a variety of cities and states around the country to help them think about this, because as we reopen, this actually becomes more, not less, necessary. And what I would say is that, for example, right now in Massachusetts, the average case has 2 to 3 contacts, maybe up to 5, but people are doing a good job of social distancing. Once we start reopening, then that contact tracing may go up to 10 or 15. And we know that that is why this core of people who can do this function are so important. And let me just say that in countries, even with far fewer resources, who put in contact tracing and supported isolation right away, like Rwanda, they were able to hold from their first 2 cases and going in the first month to only 134. Whereas the state of Georgia, for example, went from 2 cases and in 1 month had 4,400 cases. So you can do a lot once you get your caseload down, and even before, we would argue.
I think it's an interesting cultural relationship between our country and others as well. And again, it's difficult to compare, you know, the U.S. versus China, et cetera, but they were able to get it under control pretty quickly. And even you would say Europe. What's your advice to young people in this country who aren't taking it seriously enough?
Well, I don't know if my advice to young people is, I don't think it's really about young and old. I think it really is, maybe there are some young people who aren't taking it seriously, but I think leadership is critical. There, in every epidemic I've worked in, and I've worked in infectious diseases for 25 years, and in every epidemic I've worked in, what really changed the paradigm of people accepting the reality, doing the things they needed to do, was really about leadership and the good example that was set by leaders. And so, you know, when we started our work in Liberia, people said, well, Ebola isn't real. It's just like the protests here saying, you know, COVID is a hoax. But leadership is what changes that. And so we've seen very strong leadership in the state of Massachusetts by Charlie Baker. And if you walk around, our governor, and if you walk around the state of Massachusetts, nearly everyone is wearing a mask. And social distancing is taken seriously. So I think we need to create the enabling environments. And then many people can't quarantine, isolate, social distance because they need money. They have to work. They have to get out of the house. So how do we enable them to take it seriously? So I'm less concerned about the behavior of individuals than the leadership and the planning that we put in place.
That is a very prophetic comment you're making there. And Scott and Michael, I'd like your opinion. What do you think with respect to changing the paradigm by reversing the trend through leadership? Scott.
Well, I think that it's really about leadership. I think that you really hit it on the head. I think there's leadership at all different levels. We see leadership at the local level, at the village level, at the state level, at the federal level, in different forms. I think that we are being challenged. Leaders in the U.S. are being challenged. I see that colleagues across the country and health agencies are leaving their jobs. They're being threatened. I think that is a failure of leadership. I don't mean on their part, of course. I mean on the part of just broadly leadership and allowing this divisive nature to really come across in our country. You know, we really have these divides. We see the divides in the country every day. We see it extraordinarily in fine detail with testing. We've seen it from the early days of testing where communities of color and disadvantaged communities were not able to get tested. So that to me is also, again, a failure of leadership at many levels. So it's critically important that as we think about where we go from here, that we take that into account and we really as a nation, not just as a nation, but as a laboratory community, this is really something that can bind us together. Figuring out how do we get out of this? Where do we go from here so that we don't ever repeat this again?
I need to turn to Dr. Mina for his opinion. I want to frame it a little bit differently, Dr. Mina. I'm going to ask you to think about what Dr. Mukherjee said, and that is there are segments of the population in the United States that don't necessarily have or not afforded the same threshold of social distancing. I'll give you an example. Yuma County, where the migrant workers are in Arizona, the Native American population portions of Arizona as well, where you're seeing a very large surge in these populations. Partners in Health works very closely with these groups. But in your opinion, what would your advice be around leadership to help curtail this issue where healthcare disparities are more prevalent?
I think, I mean, leadership comes in a tremendous number of forms in the United States. It, you know, in some ways it starts at the White House and goes all the way down to, you know, to leaders within households. I think when all of this was getting started, I remember a senator called me up back in March and said, what can somebody in their position do to help out with this epidemic? And at the time I said, I think one of the best things that leaders can do is to start socializing people through their platform and the attention that they get just by speaking, to socialize people to understand that this is a virus that's not going away on its own. And frankly, that the more success we have early on from a public health perspective, that is going to be perceived by the public as something that success in public health often makes it look like the threat is less and less important. And so I think one of the things that we can do to try to have leadership that actually affects change in all different communities, whether they're disadvantaged or not, is really to push the message that that we need to remain vigilant. We need to sort of just make it cool to wear masks, make it completely acceptable, and make it awkward to not wear masks. That's if you go out on the street here in Massachusetts, in Boston, if you're not wearing a mask, it feels awkward. And I think that in the middle of a pandemic, that's a pretty simple thing to do if you have it. And so another thing that leaders can do is to give masks away for free, get pots of money and give them, have them available, as readily available as possible. They're extraordinarily cheap compared to other interventions that we're putting in place. And that alone will really promote the use of them. It will promote just keeping in mind public health, because mask wearing, it is about personal health, but I think that the act of wearing a mask is also anyone who's wearing it and they don't believe that they're sick, they're fully understanding that they're understanding sort of in some implicit way that this is a public health measure. And I think having the resources available everywhere around us is just incredibly important, and those types of activities can go a long way.
Dr. Mina, thank you for mentioning that. I didn't queue you up for this, but you've given me an idea, and I think I'm just going to make a proclamation right now. ASCP has a program called the Patient Champions Program. We provided masks that we're all patients in this world, and you can be a champion for other patients. Anybody who's listening to this particular broadcast, if they would like a free mask from ASCP, we will send it to you, okay? ASCP Patient Champions masks are available, and in fact, this is a critical role to make it cool again, right? And to remind ourselves, just like you said, that we all have a responsibility as patients to protect all of our patients. So thank you for bringing that up. I wanted to ask you, Dr. Mina, about your idea of a global immunological observatory. And I guess I'll frame this around the lines that, as we mentioned earlier, ASCP developed a national testing strategy to apply to COVID and other pandemics going forward. As Scott indicated, we can't face this again. We can't look at this again. We have to have protocols that when the next one comes down the pike, we can jump on this where we're not looking at a threat both to the economy, as you mentioned, as well as, more importantly, to the patients' lives that have been lost. But from your standpoint, this global immunological observatory, what's your vision about the role of U.S. academic, private laboratories to synergize in that observatory? Tell me about that.
Yeah, so the goal of the Global Immunological Observatory, or just the Immune Observatory, is to create a new model where public health, at least in the United States, where we actually start having public health laboratories that can be private and can be, but to make laboratory testing, use the data that comes from laboratory testing, whether it's private labs, public labs, not-for-profit private labs, which is what I'm really pushing for, to start getting all of these laboratory tests out of the notion that every time somebody gets tested, it has to be by a physician, that it has to be for a clinical indication, and actually start using testing, clinical and surveillance testing, to do public health in a way where we can get millions of samples, have the data that comes from. In this case, it would be coronavirus antibodies. But you know, the interesting thing is the moment you have that sample in your hand, if you decouple antibody testing from the clinical world, from CLIA laboratories, or not even from CLIA laboratories, but from reimbursements and insurance and CMS reimbursements, if you just say, we want to do an antibody test, it's actually extraordinarily cheap. Once you have the sample in your hand and you have the antibodies eluted off of it, you could not just run antibodies for coronavirus, but at the same time, you can run antibodies for 50 other pathogens. Or in my case, I developed technology that allows us to run it for hundreds of other pathogens at once for $5. So you get 100,000 different antibodies. You get signatures of pathogen exposure for $5. So if we can do that, and we can, then I think that we could roll this type of technology out to the world and be able to set up satellite laboratories, able to use these tools so that when people donate blood or come into the hospital or just out of their own curiosity want to send a dried blood spot in to be processed, that we can also gather all the information of all these other pathogen antibody responses and start immediately feeding that into sort of a weather forecasting system for pathogens. So that I envision a day when we can all go onto our iPhones or our computers and we type in a zip code and we can look up, you know, my kid has a stuffy nose today. Oh, well, it turns out rhinovirus index is very high this week. You know, I think we can do that. We're at a place where it's possible. It's just, we just need to put the mechanisms in place. And had we had it in place in the US or across the world, we would have seen that this pathogen was traveling much more quickly than anyone thought. You know, the most recent modeling estimates suggest that there were 20,000 cases in New York before the first tests were really rolled out. So there's no excuse that we didn't have systems that could have detected that. And serology is really fascinating because we can actually bank on cross-reactive antibody responses to, if we use different, more flexible assays, we would have actually been able to use assays built years ago to detect responses to this particular pathogen. So there's a lot of new tools in the pipeline that I think can make the weather forecasting for pathogens a reality today.
Fascinating. I want to get a little bit into the testing. We've been discussing testing throughout most of our town halls, but I'd like to get your perspective, all of the panelists. And I'm going to ask you first, Michael, then I'm going to move over to Scott and get your perspective as well. Where are we with point of care testing? I mean, you make the point that there ought to be a way to crowdsource an opportunity to look for myriad paths for testing and what that etiology of those diseases might be. But where are we with point of care testing where we can really do this much more rapidly? Instead of looking at the newsreels of people sitting in their cars for 6 hours to get a nasopharyngeal swab.
Mm-hmm. So we're, I think at the earliest, we're a few months away from cheap point of care testing. The assays are getting there. And in fact, we have a preprint, I think it just went up today, maybe not. But one of the big bottlenecks in point of care testing and these really rapid turnaround turnaround time tests is that they generally are having a hard time getting the sensitivity to the place where we really need it, which is, you know, well, I should say to the place where it's perceived to be needed, which is around the same limit of detection as quantitative PCR. But in reality, you know, the number of the amount of time when somebody's infected with this virus, by the time the virus actually becomes detectable on PCR, it's well into very rapid exponential growth. So the actual window of time when a person is sitting between a very high sensitivity assay and a low sensitivity assay is hours, not days. So really what we're talking about, if we're going to delay the rollout of these very fast, very cheap point of care tests because they can't get to a limit of detection of, you know, of a few RNA copies per microliter, then then we're really not looking at the big picture, which most of the false negatives when we use less sensitive tests are actually on the recovery phase of an infection when people are no longer even transmitting. And so I think that the reason I bring all of that up is because we could actually, today, we work, there's a number of companies right here in Boston and Cambridge that are developing very cheap, very fast point of care tests and also in San Francisco, I know of a few, and they're all getting hung up on getting down to the sensitivity of PCR. And I think if we can get out of that mindset and say, you know what, having 2 orders of magnitude reduced limit of detection or increased limit of detection is actually okay if the trade-off means that we can have results in 10 minutes for $3, then you can really tackle outbreaks in a much more efficient way than more expensive quantitative PCR.
What about an at-home kit, like a pregnancy test?
This is exactly what I'm referring to when I'm saying they're a little bit less sensitive. These are the at-home point of care pregnancy test looking things. They're little paper strips with sometimes with different proteins on them to capture a virus. And they can be made very cheaply because you can just print millions of them actually pretty rapidly, and they could be shipped out. I think that maybe in the new year, we might see college students, be given a little pack of test strips that they use every other day before they go to class. And I do think that that's becoming a reality, and we should expect to see it in the coming months, I think.
Hopefully we can also use that for employees to get back to work as well, to determine if they need.
Absolutely, yeah.
Scott, let me ask you your opinion when it step into the testing conversation, because again, you mentioned earlier that you work so very closely with the CDC, and you found that very useful, as you indicated, in the laboratory community. But there has been a challenge from the beginning, around logistics and supply chain. And what do you think the U.S. needs in place going forward to ensure that maybe there is rationing, or do we really need 4, 5, 6, or 7 platforms running concomitantly in one laboratory against the same test? Can that be avoided? What's your opinion on that?
So I think that we really do need something that a number of us work on globally. We work with other countries all the time on developing a national laboratory policy. We don't have a national laboratory policy in the US. We don't have a national laboratory strategic plan in the US. And I think hearing Dr. Minna talk about the innovations that we're seeing, I think we're going to need regulatory reform. We need fast pace innovation, but we also need this national policy. We need a way to, again, as I mentioned earlier, bringing the community together so that we can really look at the supply issues. I think, Blair, you're absolutely right. The fact that a number of our laboratories were using 5, 6 different platforms, they had to do that because it was the only way to survive the day, because the supplies just weren't there. We at APHL, we do a survey every week, and we've done this for now, I think 12 weeks. And we ask a question, which is, where are you on supplies? How close are you to running out? And fully a quarter have the potential of running out in any given week today. So there still is this just desperate need to bring, when I say the community, it isn't just the lab community, it's test developers, it's the suppliers. That is going to take leadership. It's going to take federal leadership. Until the Assistant Secretary for Health, until Brett Jawad was named as the testing czar, as he was in early March, there's no one person in charge of pulling this community together, pulling this system together. We don't think about systems. Now, in laboratories, of course we do. We think in systems all the time. In public health, we think about systems, but we've never really thought about a national laboratory system. And I think that the strategies that ASCP is pursuing and others really get us much closer to that place, but it is going to come back to the leadership. And I think it's something that has to be done. I think we need to think about doing this, honestly, in the next 3 months. We're going to experience a lot in the next few months over the summer. We're going to experience a lot with flu season and dealing with, you know, the potential second wave, et cetera. But I think there's so much that can be done, but it's going to take everyone sitting down at the same table.
That's,
Oh,
please,
sorry.
please.
No, I would just like to say, you know, I mean, I agree with everything Scott is saying, but I also have to say, as a person who has spent the majority of my career in low resource settings and now coordinating and supporting the Massachusetts effort and our efforts around the United States, I can say a big problem here is we don't have a health system in the United States. Rwanda has a health system, right? Even very impoverished countries like Malawi have quite good health systems where primary carers report into hospitals, community health workers reach out into the community, the district hospitals feed up into national hospitals. We have an extremely fragmented system at all levels. So it's not just the laboratory. And one of my big concerns, and for me, working in suddenly in this very wealthy country, the United States, with a very broken and fragmented system, has been nothing short of heartbreaking. And I have to say that we could have the best innovation in the world and develop a vaccine tomorrow, and I'm quite sure that the tests or the vaccines that we develop would not get to the communities that are most vulnerable. We see Black and brown people dying at 2 times the rate, getting infected at many far greater. And it's not for the lack of any particular technology, it's because we have allowed this massive economic and social inequality to kind of shape who we are and shape our health system. So we've got to really think about that. How do we pull everybody together at one table, but how do we put equity front and center as we're addressing this terrible pandemic?
I could not agree with you more. In fact, that is a perfect segue to our audience participation who have been standing in line and queuing up their questions. So I'm going to dive right into this. And I think, Joy, you're the best person to answer the first question is going to come down the pike here. And let me read it to you. Renee Narja says, I'm an epidemiologist at a local health department. And one of the most affected populations are Latinos, making up 6% of our cases, but only 16% of our population. Is there a national standard on collecting race and ethnicity standards and data when collecting a specimen and sending it in for testing? Because a very large proportion of lab reports are missing these data. And it would be great to have it if we're going to go instead of waiting for contact investigation. What's your opinion on that?
Yeah, I mean, I would say amen to that, because if we don't look at disaggregated data, we will never get the true picture of the epidemic. As I started by saying, all epidemics are quite local. And so we are currently, Partners in Health are currently working with a group called the Coalition of Immokalee Workers in Florida, a group of organized farm workers. They cannot easily get the state to test them, because the state of Florida wants to just count people who are quote unquote Floridians. And if you're a migrant coming through, if you're a snowbird that's going to go back up north, they're just not interested. They don't want to count you in the statistics. I mean, and if we are going to deal with this epidemic, you have to deal with the most affected populations, and the most affected populations are people who are historically oppressed and marginalized. And so for us at Partners in Health, the idea of collecting disaggregated data and really looking at the groups, the populations. Look, we know in the United States, zip code is the most important factor of who lives and who dies. And in my city of Boston, you can take the T from Ruggles Station to Back Bay, and you transit a 30-year difference in life expectancy. So until we figure that out, COVID is just going to manipulate that line, that fault line in our society.
The next question comes from Kelly St. George. And anybody feel free to jump in on this one. Michael and Scott, this may be a good one for you, but it says, in the workplace, in the healthcare setting, what do you consider contact? What is contact? For contact tracing, is it when an individual is either a fellow employee or a patient is positive? What do you consider the term contact? Is it somebody that hasn't been 6 feet in front of you, or somebody you saw across the bar last week?
Well, Joy might have a better answer than I do, but this was a big question, and it's remained a big question about what defines this. This came up right away when cases started coming into the hospital, and we started saying who needs to be isolated or who needs to be quarantined if they've been around somebody who's infected. And there were all sorts of answers. Initially, it was if you've spent 2 minutes with somebody within 6 feet of them, and then it was if you've spent 10 minutes with somebody within 6 feet of them. And so I don't know that there is a formal, well, there might be a formal definition that is being used, but I'd say from a biological perspective, I don't think there's good data to drive any formal definition at the moment, with the exception of saying simply, if you've been around somebody who's been fulminantly ill and spreading the virus, it only takes, it's not like it needs to be 10 minutes, for example. It can be a pretty quick transmission. It just, in some ways, it's the luck of the draw.
Joya.
Yeah, I mean, we're using and I agree with what Michael is saying, that there isn't, part of the dealing with a novel virus is that we don't have a lot of data, right? But we are using in Massachusetts the modified definition that the CDC uses, which is within 6 feet of a person for 10 minutes, more than 10 minutes, or being very close contact with someone in the same household. So, and that was used in Singapore successfully. I think a lot of these contact definitions also do rely on symptoms, and I feel fairly comfortable with that. There is some discussion of asymptomatic spread, but I think the real spreaders are the people who have symptoms. And so what we're using in Mass is that 10 minutes, and then for 2 or 3 days before your symptoms started. So it's not a black box. And I mean, that has worked with a lot of different contact tracing efforts, even though we understand there may be some asymptomatic spread.
And I understand the science is still evolving around asymptomatic patients.
Exactly.
It seems that at least the prevailing winds at this point are that patients who may have a fever or who aren't coughing, aren't spreading it through nasal droplets, aren't sneezing. It's not just being breathed on in the supermarket, but it's going to require an actual transmission of the droplets, as opposed to a person with a fever or a person who may not feel that well today. It's when you're actually expressing that virus. Scott, here's a great question for you from the panelists, and it's from Catherine Johnson. She says, how do testing manufacturers fit in the communication activities between clinical labs and public health labs? What's your opinion on those manufacturers and their communication with laboratories in both sectors?
It's a great question. There's they are right smack in the middle. They know who they're selling their products to, and many of these companies are very, very interested in doing the right thing. So I think that the lessons learned from one sector get translated to another sector. So the companies, I think, play a very important role. As I mentioned, I think moving forward, they play a critical role with us. And I think that it falls in suit with the communication. I do want to go back to the previous question, because I do have actually a comment about the contact tracing, especially as it relates to the asymptomatics. One of the innovations that we know is coming is exposure notification. And that's something, again, it's an innovation, it's new. As with everything else with this novel virus, we're going to see how that goes. I think we're going to be reading and seeing a lot more about that in the next probably 3 to 4 weeks, because it's about to take off. It could be quite helpful for us to be an adjunct to the contact tracing core that's being stood up around the country.
Okay. This question comes up very commonly in our town halls, but I'm going to ask all of you to put your Nostradamus hat on. Okay. Look into your crystal ball that's sitting there on your table, because I know that each of you have one. Everybody wants to know what the issues are going to look like in the next 3 to 4 to 6 months. And it surrounds the issue around, can our kids go back to school? Can kids go back to college? Is there going to be an opportunity to at least change the culture of embracing social distancing, where there could be a potential spread amongst a population that may not be as vulnerable, but in fact is and could be particularly a significant contributor to the spread of this disease. So, okay, Michael, put your Nostradamus hat on. What's your opinion on this one? And what's your crystal ball say?
Yeah, I think cases will continue to climb. Unfortunately, and even if they come back down again, hopefully in the near future, maybe they'll somehow stop climbing. But I think once we hit the fall, the world has not yet experienced this virus during a peak, sort of what would normally be called would normally be the coronavirus season, which is often October, November, December. And it's a little bit difficult to discern the real role of seasonality here, but this virus likely isn't particularly different from its nearest neighbors. It's acting in almost every way. It's acting very as anticipated, overall. And so I think we can expect that we will see a pretty significant transmission pickup. And right now we're in the lull. We're in the real valley of when transmission is usually at its lowest. And so if we're still seeing cases climb now, I think of this as essentially, if you think of the United States as a forest, when the whole thing got started, it was a few sparks on the edge of the forest that have essentially that engulfed the US, and we were able to put a lot of those big fires out, and now we're still seeing some brewing. Come fall though, if everything keeps opening up, it's not going to be a few sparks. It's tens of thousands of transmission chains potentially that could ignite, and that's a real epidemiological concern. And I just don't know the way around it unless we get cases down to very low levels before that. I don't think it looks like a good outcome for the fall.
Well, Dr. Mukherjee, you actually alluded to this earlier when you were describing systems that allowed for prevention and transmission much more efficient. Okay, and the irony is you're talking about third world countries for the most part doing a better job. African countries where it seems to be very low, despite the fact that they've got populations in the billions in sub-Saharan Africa alone. So let me ask you to look in your crystal ball. You've kind of talked to us about what those barriers were in the United States, but what do you think, as an American citizen, what do you think is going to be the issue coming forward in the next 3 to 4 months? What's your crystal ball tell you?
Well, as Chief Medical Officer of Partners in Health, as a professor at Harvard, and as a mom, I have differences of opinion. And I have to say, as the mother of a school-aged child, I think we're going to have to figure something out for childcare and for school if we are to deal with the economic situation in our country. And so I would imagine that educators will have to be looking at split shifts. I mean, many of the schools in the United States are quite overcrowded. I live in a very affluent neighborhood, and our schools have 25 to 27 students in a classroom. That's a lot. And there's no 6 foot between each student. So, even with good contact tracing and the ability to jump on things, and Massachusetts does have a, fairly nicely declining count of infection. But I feel that the school issue, daycare, this is going to really come to a head. It has become impossible for caregivers to work. And so I feel like this should be, every brain should be working together on this. How can we do this? What is safe enough? What is not safe enough? And I just think keeping the schools shuttered for another month, 2 month, 3 months. You know, certainly in West Africa during that Ebola epidemic, children missed an entire school year, sometimes even more. And that was extremely difficult. And I can't imagine what that's going to look like, but I'm very worried that we will not have the systems in place to reopen schools. Look, you know, there are counties in Florida that have more cases right now than Italy had at the, and that we all thought, oh my gosh, I hope we never become Italy. We have counties that look like that now. So, you know, we are not in a good situation in the United States at all.
And I guess it goes without saying, since you're our expert on contact tracing, that it's really not possible to get to 0 cases using contact tracing, is it? I mean, do you think that's going to be a possibility in the next 3
years? Look, you can, but what it takes is political will. What it takes is political will, organization, and really for everyone to focus on finding cases, isolating, supporting people. I mean, you know, this is, yeah, I totally think it's possible. Look, I was involved in the Ebola epidemic when the last case of Ebola was found in rural Sierra Leone in a county called Tonkalili. Nobody's ever heard of Tonkalili. And yet when you cross this invisible barrier, you would get out of the truck, get fever screened, you know, and everyone says, oh, Ebola was easy. It wasn't easy. It wasn't easy. It was happening in like a firestorm. And we just don't have the will to do these things in the US. That's the thing I think is missing, is the will.
Well, Scott, what's your opinion? Let's say, assuming there's not a vaccine in the next 3 to 4 months that's distributed to the public at large, and I'm not saying that there won't be, but let's make that assumption going forward in a conservative manner. What's your opinion? What's your crystal ball tell you in terms of public health and what it's going to look like for the public to get back to some kind of normalcy, as Joy was saying, and even in terms of education?
Yeah, I think that there's not going to be normalcy the way we knew it. I think, you know, we've overused the term new normalcy. I don't think we even know what that means yet, for all the reasons described. In terms of a vaccine, the idea that a new vaccine that is developed and there's enough supply, it is, you know, it's going to be very challenging. And, you know, I hear folks in the government talk about the vaccine possibilities coming up at the beginning of the year. I'm certainly hopeful for something like that. My crystal ball is a little bit murky. We've not been through this, so we don't know the seasonality. We don't know. There's a lot of things we still don't know. I also agree that it is about will, but it's about personal will. So we can have the mask, or, you know, keeping all the, you know, putting in public health orders in place, doing all sorts of things. It is going to come down to the individual will of people wanting to do this. I think with schools is another natural experiment that we're really about to go through. I have 2 college-age kids, and we're sending them off. One is going to have fully online classes. Not a great way to learn. The other one is going to have a mixed bag, really challenging. I feel for the parents and the folks with younger kids. I'm on a reopening committee for our religious school program, and these are really, really tough decisions. I will point out, though, that the YMCAs have done a fabulous job of keeping their childcare open throughout. They've done a marvelous job. So that may be a place that we can really start learning what are the things they did.
And Scott, we're going to leave it with one last point to this poignant against what you said earlier. And that was Scott Andrews is saying that this country does have a healthcare system that seems to be falling, let's say, at least nascent compared to other systems, as was mentioned earlier. But it does require national coordinated systems, and hopefully you and APHL and efforts of Dr. Mina and you, Dr. McCurry, obviously help us get through this and find a way and a path forward. Thank you all. We're going to wrap it up. If you could stay on for a few minutes. Again, thank you for all of your incredible insight, both you, Mr. Becker, Dr. Mina, and Dr. McFurgy, for your insight. While we can't say this pandemic is necessarily going to end, obviously, in the next couple of months, it's going to vastly look different than what it looked like 6 months ago. So let's take what we've learned today from these experts about SARS-CoV and COVID-19, that we can help better educate not only our physician practitioners or pathologists, but also our medical laboratory scientists at large. Thank you again for sharing your insight on how to curb this pandemic. Before we sign off, I want to share some information with our audience. It has been recorded, this town hall, so you can view it later if you like. Share it with colleagues. Here's the URL that allows you to do that. Available on the site, you'll see this URL come up within the next day or so. And in fact, you can get available CME and CMLE credit for this and claim your credit at the same time when you go on to ASCP/town hall. And because we're in the midst of an ongoing pandemic, the ASCP annual meeting, our conference has actually decided to go virtual this year. We invite all of you to join us on September 11th through the 9th for ASCP 2020 virtual, where you're going to be able to participate in this particular timely education experience in a very dynamic way, incredibly dynamic. In fact, you might think you're at an annual meeting, and we're going to connect with you in a global community as well. It's free. It's free for ASCP members, and please go onto the website at ascp.org/2020 as well. Our next town hall is scheduled for Wednesday, July the 8th at 7 p.m., where we're going to be discussing COVID-19 and the patient, how the pandemic is escalating around health disparities. With that, thank you again to our panelists. Please, everyone, have a great evening, and please stay safe.
Thank you.
Thanks.
Thank you.